Good afternoon. I'd like to thank the organizers of this conference for inviting me to speak to you today on neonatal lymphatic disorders. I used to refer to the lymph system as a forgotten circulation, but I don't think that's true anymore since over the last few years we've improved our recognition of these disorders, especially in the neonatal population. I have nothing to disclose. My objectives are to review the lymphatic imaging and interventions. I'll also go over types of neonatal lymphatic disorders that we diagnose and discuss some of their outcomes. Before I get into imaging and interventions, I wanted to review lymphatic anatomy. Approximately 80 to 90% of the lymph in the body is generated below the diaphragm, mainly from the liver and intestine. The lymph vessels from the liver, intestine, and soft tissue all converge at the cisterna chyli, which then sends the fluid up towards the central thoracic duct. The thoracic duct conducts lymph into the venous system through the innominate, subclavian, or internal jugular vein. Lymphatic fluid is made up of white blood cells with a lymphocyte predominance, immunoglobulins, proteins, coagulation factors, and triglycerides. Fluid that is suspected to be lymphatic in origin is generally tested for lymphocyte count, albumin, protein, and triglyceride level. Some patients who have a high volume of lymphatic drainage may actually present with either coagulopathy, immunodeficiency, or hypoalbuminemia. We know that lymphatic vessels contain valves similar to those in veins, and they maintain a unidirectional flow of fluid towards the central lymphatic system. The video on the left here shows the contraction of muscles within the lymph vessel wall, and fluid is being propelled through the valve in one direction. The blue arrows in the fluoroscopic image on the right are pointing to the valves within the lymph vessel. Factors that affect the flow of lymph include pulmonary blood flow, intrathoracic pressure, central venous pressure, disruptions in lymph channel formation, certain medications like furosemide, activity, and diet or fluid intake. In a study using a lamb model, it was found that chronic increases in pulmonary blood flow led to lymphatic congestion and decreased flow through lymphatic vessels. Increases in pulmonary blood flow over time also caused structural changes in the pulmonary lymphatics, and these vessels became larger and more dilated. When we suspect a lymphatic flow disorder, we try to obtain imaging, which we hope will help us make a diagnosis. I'll go through these different types of imaging techniques. Non-contrast T2-weighted MR lymphangiography is the only non-invasive method of imaging the lymphatic system. Slow-moving, non-bloody fluids produce a high T2 signal and are therefore easily visualized on MRI. This technique has typically been used to assess the anatomy of the peripheral lymphatic system in patients with lymphedema, but can also be used to diagnose lymphatic malformations as well as see segments of the central anatomy, including the thoracic duct. The limitation to this type of imaging is that it doesn't provide any information about lymph flow, and the lack of contrast does make it difficult to see the smaller channels. There are 4 types of lymphatic abnormalities that we can see on T2 imaging. Type 1 is essentially normal. When there's perfusion into the supraclavicular region, it's called type 2. Type 3 is abnormal flow extending to the mediastinum, and if the abnormalities also include the lungs, it's type 4. So minimally invasive method to image the lymphatic system is through intranodal lymphangiography. This technique begins with inserting small needles into the inguinal lymph nodes. Through these needles, contrast is then injected and the lymphatic system is imaged fluoroscopically or with MRI. The image on the right is an ultrasound view of the lymph node highlighted by the white star, and this white arrow is pointing to the needle that is entering the lymph node. Lymphatic imaging that requires intranodal access is typically performed in an XMR suite like the one pictured here. The inguinal lymph node needles are placed in the first part of the suite on the left. Once needle position is confirmed, the table that the patient is secured on can move along a track into the MRI scanner, or they may stay stationary if it's undergoing fluoroscopic imaging. If the patient is to be moved into the MRI scanner, gadolinium is then injected into each lymph node. 1 minute after the initiation of injection, scanning is started. These images show a typical time course of contrast moving along the central lymphatics, with image C showing the thoracic duct lit up in a normal person at 430 seconds, or about 7 minutes. Imaging the flow of fluid within the lymphatic system using MRI is called dynamic contrast enhanced MR lymphangiography, which is also referred to as MR lymphangiography or DCMRL. This video shows the pattern of flow from the inguinal nodes up to the thoracic duct in real time. After DCMRL, if a more detailed look at the thoracic duct outlet is needed, we proceed to direct lymphangiography. In this technique, the lymphatic system is accessed transabdominally using a 21 or 22 gauge needle. To prevent leakage of chyle from the cisterna chyli, access to the lymph system is obtained through feeder vessels just below the cisterna chyli under fluoroscopic guidance. Using this access, a microcatheter is then inserted directly into the thoracic duct and contrast can be injected. A newer alternate method to assess patency of the thoracic duct outlet is by using contrast-enhanced ultrasound. Using the inguinal needles that were placed for DCMRL, ultrasound contrast is injected, followed by imaging of the left or right neck until the contrast appears. These images were taken from a 2020 study describing contrast-enhanced ultrasound. Image A on the top of the slide is the ultrasound view of the left internal jugular vein and proximal innominate vein before contrast injection. In image B, the arrows pointing to the passage of contrast into the left internal jugular vein, and the arrowhead is showing the contrast then extending into the innominate vein. These findings confirm the patency of the thoracic duct outlet. Image C is the DCMRL from the same patient. The arrow in this image is pointing to the thoracic duct, but because of the abnormal lymphatic networks up in the neck, the outlet was not able to be visualized on this imaging. So once we've visualized the disruption of the lymphatic system with one of the imaging techniques I described, we can determine if any intervention is the next best step. So I will review lymphatic embolization, specifically oil injection, as well as lymphovenous anastomosis and thoracic duct externalization. Embolization begins with inguinal lymph node contrast injection so that the thoracic duct can be visualized. Once there is opacification of the lymphatics seen in this image on the left, a needle can be introduced transabdominally to access the thoracic duct. A wire is then placed over the needle and advanced to the site of the abnormality. The image on the right shows leakage of contrast at the top of the thoracic duct, and so this is the area in which the coil or glue may be deposited. The same technique is used to selectively embolize abnormal vessels that branch off of the thoracic duct. Ethiodized oil can also be used for selective embolization of lymphatic channels and is commonly the treatment of choice for chylothorax. This oil is a radio-opaque contrast agent that is made up of iodine and poppy seed oil and has been in use since the early 1900s. Due to its high viscosity, it results in mechanical occlusion of abnormally conducting lymphatic vessels. It is also believed that it causes an inflammatory reaction within the vessel wall, resulting in the sclerosis. This type of treatment also requires inguinal lymph node access for it to be injected. Image A shows the contrast moving up the lymphatics towards the cisterna chyli early during the lymphangiogram. Image B shows the oil migrating into the abnormal pulmonary lymphatic vessels, and image C shows the appearance of the retained oil on X-ray. If a thoracic duct outlet obstruction is found on imaging, the treatment may be a lymphovenous anastomosis. In this intervention, a lymphatic vessel in an affected area of the body is connected to the venous system in that same area. This allows the excess lymph to drain directly into the venous circulation, bypassing the abnormalities. Historically, this technique has been used for many years to treat adults who undergo lymphadenectomy for cancer and then go on to develop lymphedema. More recently, this technique has been used in infants who have had thoracic duct outlet obstruction. In 2018, Weissler and colleagues reported on 2 successful cases of lymphovenous anastomosis done at the Children's Hospital of Philadelphia. Both were infants who had congenital heart disease and developed chylothoraces after cardiac surgery. One of the infants developed a venous clot, and the other infant's thoracic duct was disrupted during the surgery. During this procedure, the lymphatic vessels and thoracic duct are accessed either transabdominally or intranodally so that dye can be injected to highlight where the thoracic duct is. The video on the left shows a thoracic duct in blue, now connected to the external jugular vein. The video on the right is a subsequent fluoroscopy showing a patent connection between the 2 systems. So now that we've reviewed imaging and possible interventions, the remainder of my talk will be reviewing cases of neonatal lymphatic flow disorders. When there is overproduction of fluid or conduction abnormalities, it can result in lymphatic fluid perfusing abnormally to various organs. When lymphatic flow is just to the lungs, it results in pulmonary lymphatic perfusion syndrome. And when there is abnormal flow to 2 or more compartments with the presence of edema or anasarca, it is referred to as central lymphatic flow disorder. Patients with CLFD have either a congenital absence of their thoracic duct or an anatomic obstruction. Some patients develop a functional thoracic duct obstruction, which typically occurs in the setting of elevated central venous pressure from a clot in the venous system. It can also occur in the setting of high intrathoracic pressure that we sometimes see in our patients with bronchopulmonary dysplasia. This is a case of a 27-week gestation triplet who was one of the first patients evaluated and treated for a lymphatic disorder at the Children's Hospital of Philadelphia. At 2 months of age, she developed bilateral chylothoraces, which were medically managed with chest tubes. At 4 months of age, she had a tracheostomy placed for BPD. This picture was taken after her tracheostomy was placed and shows how severe her anasarca became. We believed her dramatic swelling was secondary to increased central venous pressure and disruption of abnormal lymph channels in her neck. The video and image here were taken from her MR lymphangiogram and shows dermal backflow in her abdomen, abnormal lymphatic perfusion to the lung, and a lack of flow from her thoracic duct to the venous system. Given these findings, she met the diagnostic criteria for central lymphatic flow disorder. This video and image were taken from the direct lymphangiogram that was done to better assess her thoracic duct and shows her abnormally dilated and tortuous duct with insufficient drainage from the outlet to the venous system. Because of these findings, a decision was made to externalize her thoracic duct to allow her lymphatic fluid to drain outside of the body and reduce her body wall edema. This is the video and image taken during that procedure. You can see the introduction of a wire from the region of the neck that was directed into her thoracic duct. This wire was then used to place a catheter in the duct that ultimately drained lymph fluid outside of her body. Shortly after this procedure, she began draining about 1 liter a day. The graph on the left here shows her daily drainage for the first 3 weeks, and the one low point in drainage occurred when her drain was occluded, and it began picking up again after it was flushed. The graph on the right shows her weight loss over time. These are the before and after pictures. The picture on the left was taken soon after she came back to the NICU after her externalization, and the one on the right was taken 2 weeks later. So as you can imagine, during this time, her ventilator requirements greatly improved. We have had other similar patients in which thoracic duct externalization has been used to reduce overall body wall edema, allowing for surgical interventions, specifically lymphovenous anastomosis. Earlier, I mentioned that bronchopulmonary dysplasia can also lead to lymphatic dysfunction. Severe BPD is a heterogeneous disease that affects the lung parenchyma, pulmonary vasculature, as well as the proximal and distal airways. These abnormalities can lead to dynamic hyperinflation in some infants and can result in air trapping and high intrinsic PEEP. If there is a high PEEP requirement or the intrinsic PEEP is high, this leads to increased intrathoracic pressure, which in turn increases central venous pressure. This disrupts lymphatic drainage from the thoracic duct and can result in anasarca and other downstream abnormalities like protein-losing enteropathy and ascites. Increasing chest wall edema and abdominal competition requires additional increases in PEEP to overcome, and the cycle continues. This next case is a patient also with CLFD. He was born at 24 weeks gestation and was transferred from his birth hospital at 6 weeks of life. When he was 6 months old, he had inguinal hernia surgery, and ascites was found during that procedure. The fluid had 97% lymphocytes, and because of a history of loose stools and intolerance to feeds, a stool alpha-1 antitrypsin was also sent. The chest x-ray on this slide is significant for hyperinflated lungs with diffuse areas of air trapping as well as soft tissue edema. So at this point, it was becoming more and more apparent that he was developing a lymphatic disorder. This is a video taken from a conventional lymphangiogram done to assess the thoracic duct outlet. This is not the same patient, but essentially shows no flow of contrast from the thoracic duct outlet to the venous system, and instead you see contrast pooling up into the neck. This is a subsequent video taken after the PEEP was weaned, and now you can see a steady stream of contrast from the thoracic duct into the vein. Here is an image from his MR lymphangiogram. He had a large and tortuous thoracic duct, as well as a significant amount of contrast accumulating into his duodenum. Other findings were dermal backflow and leakage of contrast into the peritoneal cavity, which you can't see on this specific image. So with these findings, he was diagnosed with CLFD as well as protein-losing enteropathy. PLE is characterized as an abnormal hepatoduodenal lymphatic leak that results in the loss of proteins. Single ventricle palliation surgery is the most common cause of PLE due to lymphatic dysfunction. The main protein that is lost is albumin, and many of these patients will present with hypoalbuminemia in addition to anasarca and ascites. The diagnosis can be made by finding elevated alpha-1 antitrypsin in the stool. In our patient, his PLE was due to a functional obstruction of his thoracic duct outlet from high PEEP, both ventilatory and intrinsic, and so selective embolization of the leaking channel would only be a temporary solution. The main goal in this case was to reduce his intrathoracic pressure by externalizing his thoracic duct. So the next category of lymphatic disorder we commonly see in neonates is pulmonary lymphatic perfusion syndrome. PLPS is the result of abnormal lymph flowing retrograde from the thoracic duct to the lungs while the remainder of the system is normal. When it occurs in infants, it results in neonatal chylothorax. Although this pattern is believed to be secondary to abnormal fetal development of the central lymphatic conduction system, it's also the same pattern seen in older adults who have plastic bronchitis. This study, published in 2018, described the correlation between the prenatal finding of nutmeg lung and postnatal imaging features of neonates with lymphatic disorders. Nutmeg lung is a term used to describe a fetal finding of abnormal pulmonary lymphatic flow on MRI. It refers to a heterogeneous T2 lung signal that looks like a cross-section of a nutmeg. The authors of the study showed that patients with this prenatal finding had PLPS and chylothorax that was then confirmed on postnatal lymphangiography. The last case I'm going to present is a term infant who was prenatally diagnosed with a right-sided chylothorax. She had normal genetic studies and underwent 2 thoracoamniotic shunts prior to birth. At birth, she was asymptomatic and admitted to the NICU on room air. Enteral feeds were started with regular maternal breast milk, and as the feeds increased, she began to develop tachypnea and mild respiratory distress. The X-ray on the left was taken on day of life 0 and showed minimal pleural effusion. Due to her changing status, a second X-ray was obtained on day of life 4, and it showed an increase in the effusion size. At this point, she had lymphatic imaging done to determine if she could be treated, and this video and image was taken from her MR lymphangiogram showing an abnormal pulmonary lymphatic flow to the right lung only. A chest tube was placed and she was treated with intranodal injection of oil. Here is the fluoroscopic video of the oil injection, and you can see the contrast migrating up the thoracic duct and into the abnormal lymphatic channels on the right. A few days after this procedure, her chest tube was removed and she was placed on low-fat feeds without recurrence of her symptoms. So after several years of seeing patients with both CLFD and PLPS in our unit, we decided to take a look at the outcomes of our neonatal lymphatic population. We conducted a retrospective review of 35 patients. Even though it seems like a small number of babies, these are such rare diagnoses that this is one of the largest reviews of neonatal lymph disorders. In our cohort, there were 15 patients with PLPS and 20 with CLFD. The patients in the CLFD group were slightly more premature at birth. 80% of the PLPS group had a prenatal lymphatic diagnosis as compared to 40% of the CLFD group. And I think this is a reflection of the various causes of CLFD. All patients, regardless of their diagnosis, had a history of a chylothorax. Lymphatic imaging was performed on both groups of patients with MR lymphangiography. 85% of the CLFD group had ascites, and 42% had soft tissue perfusion as compared to the PLPS group, which had neither finding. On DC-MRL, almost all of the PLPS group had lung perfusion, but none had dermal backflow, while all of the CLFD group patients had dermal backflow. Following diagnostic imaging, 21 patients went on to have a lymphatic intervention. 11 patients with PLPS were treated with oil compared to 2 patients with CLFD. Of the remaining 8 patients with CLFD who received a lymphatic intervention, 2 received a combination of oil and glue embolization, 3 underwent lymphovenous anastomosis, 2 had their thoracic duct externalized, and 1 had a lymphatic vessel drain placed that was not in the thoracic duct. We found that patients diagnosed with PLPS had 100% survival, while patients with CLFD had only 50% survival. All 15 patients with PLPS had resolution of their chylothorax, including the patients that resolved without an intervention. We concluded that MR lymphangiography, or DCMRL, is a useful tool in determining diagnosis, directing treatment plan, and providing important prognostic information to families. We also learned by visualizing the extent of lymphatic disruptions, we can develop more targeted interventions for patients with CLFD with the hope of improving outcomes. Thank you very much for your time, and I'll be happy to answer any questions you have during the Q&A session.